So the topic is focusing on gender in cardiovascular disease. And the second main component of this topic is exploring the role of genetic factors in cardiovascular disease susceptibility among women. So I would like to touch quickly the scope of the problem, biological, social determinants, gender differences, risk factor. Regarding the conventional risk factors, it's been discussed in the first day very nicely. Emerging, unique, and gender-specific risk factors are very important, and then the role of genetic factors. So according to CDC, that's the alarming condition, and the mortality rates due to heart diseases among women is very high. Despite increase in awareness over the past decade, only half of the women recognize that heart disease is the #1 killer. And about 4 lakh deaths per year from cardiovascular diseases occur in women as compared to the other causes. In 2019, there was approximately 275 million women around the world with cardiovascular disease, and that's an alarming situation. The leading cause of the death from cardiovascular disease worldwide is due to ischemic heart disease, that is 47%, and stroke, that is 36%. Globally, the prevalence of cardiovascular disease is reduced by 4.3%. However, in China, it's increased by 10%, India by 3%. We don't have a data of Pakistan here. Less than 130 deaths per 100,000 women occur in high economic countries, whereas what happened? In low economic countries, it is around 300 deaths per 100,000 women. So, graphically, it is highlighted that the cardiovascular disease is the leading cause of death in women. This is the graphic presentation which highlights the more women are dying due to cardiovascular disease as compared to men, and this is the situation. And that's why we are coming, what are the risk factors, as we all know, and the important risk factors, the biological determinants, and the genetics is one of it. Regarding this, the other social determinants are also very important, especially in this era of post-COVID, and whatever the financial conditions globally are, the stress factors and social determinants are becoming very important. Are women more complicated than men? Is cardiovascular disease risk factors and prevention fundamentally different between women and men? Yes. They have biological differences, reproductive organ functions, genetic expressions, differences in sex hormone, anatomy, physiology, and the social determinants. Cardiovascular disease is mainly a disease of an old man, and this myth is now changing. Although less frequent, cardiovascular disease deaths occur among young women, and more than 35,000 women die in America who are under the age of 65. So, women don't need to worry about the cardiovascular disease before menopause. As we know, the things are changing, and coronary artery disease progresses before a larger time before this. So, being premenopausal probably does not protect us from a cardiovascular disease burden and underlying diseases. As we know, the women are most of the time referred lately, and that's why their presentations are different, and the death rates, according to this data, is more due to underlying coronary artery disease, and then stroke, and then come the breast cancer, lung cancer, and the rest of the things. This is the data from United States in AHA, year 2020, which highlight the cardiovascular death trends for males and women. Among males, the trend is towards a lower side. Perhaps the most important risk factor for cardiovascular disease is the misperception that the cardiovascular disease is a disease of a man. So these are the traditional risk factors, and there are non-traditional risk factors and the novel risk factors, which are very important, and we all know about these conventional risk factors. And we know lipoprotein can be more predictive in younger women age groups, as well as the diabetes double the risk of a fatal coronary artery disease, whereas smoking is associated with 50% of all coronary events in women. Women who smoke, we know they have a 6-fold more increase in underlying myocardial infarction, while on intervention, we come to know that the male have got a larger epicardial arteries with focal obstructive disease. However, the small epicardial arteries with non-obstructive disease occur in cases of females. Emerging cardiovascular risk factors are very important, and we all should have to identify these in our patients, and these are the depression, stress, autoimmune disease, oncological treatment. Inter-Heart study concluded that the psychological factors is responsible for more than 32% of cases of myocardial infarction. And the risk of developing cardiovascular disease in women with depression is more than 30 to 50 times as compared to men, and that's why the stress and depression should be considered as an independent risk for women. Autoimmune disease are considered as a risk enhancers, and cardio-oncology prevention in these patients should be very important. We must have to identify them, as well as we must have a prevention regarding the oncological treatments. So this is an important thing, that is a gender-specific risk factors, and these are the unique risk factors among women. Early menopause, hormone therapy, menarche, polycystic ovarian syndromes, hypertension, eclampsia, diabetes, gestational. And so we all should know that early menarche leads down to increased cardiovascular risk as well as coronary artery disease. And early and premature menopause is responsible in increased cardiovascular risk by 50% as compared to natural menopause. And there are specific risk factors which are included in the primary and secondary prevention guidelines. Contraceptive pills is associated with increased risk of venous thrombosis, hypertension, heart attack, and strokes. Polycystic ovarian disease is developing diabetes mellitus 5 to 10-fold more as compared to the rest of the population, and hypertension increases the risk of chronic hypertension in the pregnant ladies 3-fold, whereas pulmonary embolism by 2-folds. Gestational diabetes is a predictor of diabetes mellitus in future, and 20 to 70% of females with gestational diabetes lead to this, whereas the preterm birth is associated with future maternal risk of adverse coronary vascular diseases. Adverse pregnancy outcomes. Gestational hypertension leads to 3 to 4%, preeclampsia in 2 to 5%, gestational diabetes 5%, and preterm delivery in 6 to 12% of the patients. Adverse pregnancy outcome is a separate diagnosis. We must have to keep this thing in mind. It has its own diagnosis management, and there is an underlying pathogenesis which increases placenta ischemia, leading to maternal inflammation and vascular dysfunction. Why these risk factors are so important? We must have to identify them. Yes, one risk factor double our risk, whereas 3 or more risk factors can increase our risk to 10-folds. We are identifying them, we are doing a secondary preventions, but still the disease burden is high, the mortality rate is high. So what is important? What is the answer to that? And that is the second part of my talk, and that is the risk factor for cardiovascular diseases are categorized into 3 classes. The one, environmental exposure and the lifestyle factor, which has already been addressed since 1990 in Framingham heart studies, whereas genetic factors are very important, and this is the need of the day. We all should know about it. The answer is genetic risk stratification, and that is a paradigm shift in prevention of coronary artery disease. Conventional risk factors are inadequate to detect who is at risk in early at asymptomatic stage. That's why genetic risk for coronary artery disease can be determined at birth, and at the highest genetic risk have been shown to respond to lifestyle changes, statin therapies, to less than 40 to 50% of advanced coronary artery disease events in advanced life. Genetic risk stratification for CAD should be brought to the bedside in an attempt in order to prevent this pandemic disease.
Amber?
No doubt. Ma'am, my timer is there and that is 4 minutes left and I'm going to complete in 2 minutes. Gee, ma'am, I'm going to complete in 2 minutes. Coronary artery disease is a pandemic disease and highly preventable as shown by the secondary prevention. Primary prevention is preferred, known that the 50% of the population can expect a cardiac event in their lifetime. So risk stratification for primary prevention using the pool cohort calculators only identify the conventional risk factors, and conventional risk factors are dependent on age. So the genetic risk score, which is estimated from the recently discovered genetic variant predisposition to coronary artery disease, offers a potential solution to this problem. The GRS is derived from genotyping the population with a microarray containing with genetic risk variants, has indicated that genetic risk stratification is basically based on GRS and it's superior in identifying these patients, and that should be identified very early in age and we can treat them so that we can prevent the complications with cardiovascular disease. A study performed in more than 1 million individuals confirmed genetic risk stratification is superior and primarily independent of the conventional risk factors. So the risk stratification for coronary artery disease using the GRS has shown a lifestyle changes, physical activity, and early statin therapy, and this reduces 40 to 50% reduction in cardiac events in a high genetic risk score population. Genetic risk stratification has an advantage because it's not an conventional risk age-dependent factors dependency. Right, Ji? So this is a journey, how it has been done. They have identified the genes. The genes are then having a genomic multiple DNA predilation, and these further studies has been done. And practically now they have done a clinical trials which highlighted there are 5 novel genes, and the first gene being identified in year 2007, and that is the 9p21 genes, and these genes have other underlying diseases which is highlighted, and timely when we identify them we can treat these patients, and this is the different gene mapping which identify the underlying comorbid conditions. We identify them, treat them appropriately in early age so that we can prevent all these complications, and that is the main cycle with the help of which they identify the novel locus, then LD blocking process done, then the browsers it, and the different software programs being adopted, and then they calculate this risk stratifications. And this Manhattan plot for coronary artery additive meta-analysis results highlight that PCSK9 gene was identified and inhibitors against this being started, and that's why the statin therapy is really very advanced and it's preventive the cardiovascular risk. That is the quick review: population screening, DNA extraction, genetic risk scores, and then on the basis of this, we can identify whether it is low, intermediate, or high risk population is further treated. And that is a message from Professor Roxana Mehran from the GO-RAD that the cardiovascular disease in women remains understudied, under-recognized, under-diagnosed, and under-treated globally. So we all must hand together to develop some policies and partnerships by different policymakers, clinicians, researchers at the community level. So in order, the perception that the women represent a low-risk population for cardiovascular disease needs to be reconsidered. And that's why the experts all over the world, 17 different leaders from 11 countries, and they have identified the 10 recommendations in order to reduce the disease burden. and to tackle inequities in diagnosis, treatment, and prevention to reduce cardiovascular disease in women. It includes, as we all know, how to educate the healthcare workers and the patients especially regarding the early detection to prevent the heart diseases in women. And meanwhile, we must have to set up heart healthy programs in highly populated countries as well as in underdeveloped countries, and we should prioritize the sex-specific research on heart diseases in women so that we can have our own intervention strategies. Here in the end, I would like to request Pakistan Cardiac Society, the president is here, the general secretary is here, and please do start the registries regarding women and other diseases, hypertension, atrial fibrillation, acute coronary syndromes. This is the need of the day, so that we can have our own data and we present and we know what is the disease prevalence. Actually, what we are seeing, this is just the tip of the iceberg. The disease burden is totally different, and that is the one suggestion, and I hope we are going to inculcate this. Thank you very much.